Same tooth, different dentist, diagnosis, cost, outcomes, safety, and experience can truly vary dramatically. Dentist decisions vary widely. Moderate agreement on caries, widespread prophylaxis misuse, and big fee swings. Quality spans outcomes that last and heal, safety, right timing, patient comfort, access, and overall value. DDS and DMD are equivalent. Specialist complete residencies. Board certification adds rigor, influencing care outcome. We measure survival, function, complications, healing, and patient experience. Next, where dentists influence these outcomes most. Provider technique and experience shift results. Root canals, implants, composites. Next, we visualize volume outcome trends. More cases, fewer mishaps. The learning curve in endodontics and third molar surgery, foreshadowing the safety stakes next. 80% of prophylactic antibiotics were unnecessary. Choose NSAIDs over opioids. CBCT when indicated. Roadmap. Here's our roadmap. Training, techniques, technology, outcomes, appropriateness, kindness, practice models, safety, and interactions influencing real-world results. CODA programs set core competencies. Clinics vary. Licensure uses INBDE plus clinical assessment. Postgraduate follow. Postgrad paths expand capability. GPR AEGD broadens general practice. Specialties deliver focused mastery and advanced technique. Board certification verifies specialty training. Many practice while board eligible. All rely on education and permit. States set CE hours. Topics. Deeper sedation requires permits, equipment, escalating monitoring, and emergency credentials too. Technique and equipment shape outcomes. These tools elevate detection, isolation, and documentation before endodontic treatment. Technique choices shape outcomes. Efficient NIT, precise length, active irrigation, visit similar, coronal seal paramount. Amalgam lasts longest. Composites demand strict isolation. GIC aids carries control. Next, tech-guided implant planning. 5-year survival is high. Risk factors matter. Guided 3D planning improves accuracy. Setting up maintenance. SRP reduces pockets, modestly improves attachment. Adjuncts vary. Maintenance sustains outcomes. Next, infection control essential. Follow CDC standards. Validated sterilization, weekly spore tests, safe water lines, breaches linked to dental outbreak. Common dental imaging doses vary. Choose modality per ADA FDA guidelines using ALARA or ALADA principles. Root canal outcomes hinge on diagnosis, anatomy, disinfection, seal, and provider. Specialists generally reduce complications. Complications vary. Dry socket is common. Nerve injury is rare. Technique matters. Next, crowns versus onlay. Full crowns are robust, more invasive. Adhesive onlays preserve structure, comparable survival. Next, orthodontic planning. For similar malocclusions, plans vary. Both align mild to moderate. Rotation, torque efficiency differ. Pediatric approaches. Next, in kids, non-invasive care excels. SDF, sealants, Hall crowns, behavior guidance reduces sedation. Next, geriatric. In medically complex elders, provider comfort shapes risk assessment, consent, anticoagulants, preventive planning, and coordination. Across providers, restoration rates vary with diagnostic thresholds, even after risk adjustment. Utilization shifts accordingly. Next, pain management. NSAIDs, alone or with acetaminophen, outperform opioids. Dental opioid prescribing declines. Next, antibiotic stewardship differences. Evidence shows limited indications. Practice often diverges. Next, we apply guidelines to align care safely. EBD aligns research, expertise, and values to reduce unwarranted variation, enabling preventive, minimally invasive care. Risk-based Canberra tailors prevention. Fluoride varnish cuts pediatric caries 30 to 45%. Next, radiographs vary. Select by visit and risk bite wings, periapicals as needed, CBCT reserved. Next, variability and adjuncts. Examiners differ. Calibration helps. Adjuncts assist, mislead. Radiographs depend on technique and experience. Shared decisions. SDM presents options, risks, and uncertainties, aligning care with patient preferences, improving outcomes and satisfaction. Different practice models directly influence access, continuity, and process consistency. Fees vary. Insurance impacts explored next. Fees vary widely by procedure and region. In-network discounts reduce costs, not necessarily signal quality. Insurance has caps, frequency limits, and network pricing, helpful for costs, not measuring clinical quality. Seeing the same team establishes baselines, early detection, tailored prevention, and adherence reinforced by trust. Access and operations shape adherence and outcomes. Next, we'll assess practice-level quality metrics and performance data. Common practice metrics track prevention, evaluations, emergency caries visits, periodontal care, and key processes today. Outcome tracking varies. Few registries, fragmented EHRs. When measured, metrics improve quality, counseling, and referral. Refer when complexity threatens outcomes, endodontic challenges, surgical proximity risks, or advanced periodontitis. Next, safety readiness. With equipment, training, drills, screening, and monitoring, teams handle rare emergencies quickly, decisively, minimizing patient harm. Yes, the dentist you choose can alter diagnosis, treatments, complications, longevity, safety, radiation, and costs. Differences stem from training, techniques, evidence and safety, practice models, and communication. Next, the key numbers ahead. Procedure success rates and risks that shape outcomes and upcoming dentist choices. Variation impacts all domains, strongest in clinical outcomes, safety, and appropriateness. Patient experience, costs follow. Dental care varies, diagnosis, treatment, outcomes, safety, cost. Dentist choice affects health, quality, cost data exists. Objective, verifiable signals exist. Licenses, board directories, practice metrics, and ADA-defined measures. Use them to decide.